What's up viewers, welcome back to Medico Virally. Thank you very much for subscribing. If you haven't subscribed yet, kindly do subscribe and hit the bell icon for instant upload notification. In the last video we have discussed about the genesis of action potential, like we discussed very detailedly how the arrhythmia may be caused, and now in this video we will be discussing how we will block each of these phases, like phase 0, the sodium channel blocker, and the 1, 2, 3 contains potassium blockers or openers, as well as the calcium channel blockers. So we will discuss the anti-arrhythmic drugs detailedly. Let us make very simple. We have mainly 5 classes of anti-arrhythmic drugs. I already explained in the last video. To make it easy to remember the order of the classes, let us suppose this is a myocardial cell. So what you did, you took a myocardial cell from your heart, and now you know the cells are bags of potassium that are floating in the sea. That means cells are rich in potassium, and C means it is rich in sodium. So the outside part, the extracellular, is rich in sodium and intracellular is rich in potassium. And you know it is a myocardial cell. What is the predominant receptor present on myocardial cell? Yes, you are right, it is beta receptor. And you know there is a presence of sarcoplasmic reticulum. So the sarcoplasmic reticulum stores the calcium. That's all. Now you come from outside to inside. That is, first sodium, second beta blocker, third potassium channel blocker, and 4 is calcium channel blocker. And the 5th class includes miscellaneous drugs. This is how to remember the classes and their sequential order. Let us detailedly discuss each of the class. The first class includes the sodium channel blockers. All the class 1 drugs can have the capacity of blocking the sodium, but they are again subdivided into 3 classes based on the property of potassium channel. For example, in 1A, the drugs can block the sodium as well as they can block the potassium channel also. So 1A, A for all, so it blocks all, it blocks sodium and potassium. And 1B, it blocks only sodium and it opens the potassium channels. And 1C means C for care not. It does not care about the potassium channel and has no effect on potassium channel. This is what you have to remember. So you have to know the drugs included in each of the class. The 1A class, A means A class people or hi-fi class or first class people. Who are the hi-fi class people, hi-fi people? The queen and the prince. That is, queen means quinidine, prince is procainamide. This is the way to remember. That's it. And I will just present an image here, just a second. Yeah. So here, if you observe the image, the king, the prince is sitting here. These are the second group, that is B class people, that is they are the servants of the prince. Just this is a way to remember, that's it. So these people are serving the prince, like one is pressing the legs and other people are, they are moving the fan, they are swiping the fan for air, and other is coming by taking the topi, the prince, the crown, to put on the head of the prince. This is the order to remember, like the legs, legnocaine, the fan, phentoin, and the topi, that is tocainide. Topi means, you know, in Hindi it is a hat. So tocainide. These are the 3 drugs that are included in 1B class. So 1A or A class people, the queen and prince stay here, and 1B, the servants of the queen and prince, 1 legs, fan and topi. Okay, this is the way to remember. And the 1C has another drugs like N-cainide, flecainide and propafenone. Okay, so if you remember the A and B, you can rule out the C. So there may be an MCQ like all of the following come under the 1B, or else all of the following has the property of potassium channel openers, like 1B or potassium channel openers. Am I right? As I just discussed here, openers, blockers. And there may be another MCQ like which of the following has both the property of blocking the sodium as well as the potassium. Your options will be lignocaine, phenytoin, tocanide and procainamide. So what is your answer? Procainamide is the answer, because you know the 1A has property of blocking both the sodium as well as the potassium. So these type of MCQs will be asked here. And regarding the 1A, you have to remember one special point, that is the 1A also has the property of potassium blocker, right? What did I tell you? This is the resting membrane potential, and this is the depolarization phase, and now this is the repolarization phase, right? So the repolarization is based on the potassium channels. For example, if the potassium channel is blocked, what happens? The repolarization becomes very slow. When it becomes very slow, this action potential duration will be increased. When the action potential duration is increased, how do you identify? You can't go into your myocardial cell and you can look there and tell the patient that yeah, your action potential duration is increased. Yeah, you take an ECG and you observe the QT interval on the ECG. So if the QT interval is raised, that tells you that the action potential duration is increased. I also present you the ECG. So this is the ECG. What do you observe here? The Q and the T interval is a long interval. Here the Q and T is very short. Even here when you see, it is short. So one short, one long, one short. So when your QT intervals are long in some of the graphs, in some of the leads of the ECG, then you have to understand that your potassium channel is blocked. And then you have to go with the treatment. That's it. So you have to remember there is a risk of increased QT interval when you use the Queen and the Prince. That's all about the 1A. And about the 1B, the servants group, the legs, fans and topi. They are all used in ventricular arrhythmias. So in ventricular arrhythmias, all are used, but especially the legs. The legs is lignocaine. The legs on lignocaine is the drug of choice in most of the arrhythmias. One special condition you have to remember, for example, a patient presented to your clinic. He already had an attack of MI, and after that now he has arrhythmias. And now what is the drug of choice? You have to press the legs of the patient. It is just a way to remember, not insult anyone. Like in patient with the post-MI arrhythmias, what you have to do? You press the legs. That is, the drug of choice is lignocaine. Okay, this is just a way to remember. Lignocaine is drug of choice in most of the arrhythmias and also in post-MI arrhythmias especially. About the 1C drugs, these are mainly used in Wolff-Parkinson syndrome. We discuss about the syndrome detailedly in the medicine videos. Okay, for now you just remember this. So now that we have completed the class 1 drugs of the anti-arrhythmic drugs. About the class 2. What is the class 2 here? Beta blockers. So about the beta blockers, we will discuss detailedly in ANS. Now you have to remember only one point. Beta blockers are mainly used in tachyarrhythmias. So when you have increased rhythm, then to decrease the rhythm, you block your beta receptors. By the way, let us also cover the fourth group. The second group was beta blocker. The fourth group about the calcium channel blockers. So this was already discussed in the congestive heart failure video. That is, we have mainly 3 drugs: verapamil, diltiazem and dihydropyridines. And here dihydropyridines are not used in arrhythmias. We use only the verapamil and diltiazem. Only these 2 drugs are used for as anti-arrhythmic drugs, and dihydropyridines are not used. Even the calcium channel blockers are used in tachyarrhythmias. They are also used in tachyarrhythmias, but one special point here you have to remember is never you combine both of the beta blockers and calcium channel blockers. What happens if you combine? So it blocks the beta and also it blocks the calcium. So both the channels and receptors are blocked and your heart goes into a severe depression. So there is a risk of severe myocardial depression. That is why you don't combine the class 2 and class 4. Okay. What are we left with? We are left with the class 3 drugs and the class 5 drugs. Class 3 drugs are the potassium channel blockers. The potassium channel blockers, that is banana. What happened in the last video? I just told you a story like you are not fond of banana. So when you are not fond of banana, you block the channel and you stay bindas. And that is the mnemonic here to remember the drugs even, like bindas B for bretylium, I for ibutylide, D dophytylide. Here there is common tylide. Okay, ibutylide, dophytylide. And the next one is amiodarone, the most important drug, and sotalol. Here the bretylium is used as pharmacological defibrillator. Do you know what is a defibrillator? Yes, it is an external device which produces counter shock to your heart. In the same way, there is a pharmacological defibrillator, that is bretylium. So we use it as pharmacological defibrillator, and also it is used in ventricular fibrillations. Mostly we use the bretylium in ventricular fibrillation. But the ibutylide and dophytylide, they both are used in atrial fibrillation. So when they are used in the atrial fibrillation, they convert the abnormal atrial rhythm into a normal sinus rhythm. Then you start observe, for example, you have a patient in your ICU and he has an arrhythmia. There is no P wave observed on the ECG on the monitor. What do? You just try with the ibutylide. When you give the ibutylide to the patient, then after some time you start seeing the P wave. That means the abnormal rhythm has converted into a sinus rhythm. Okay, and that is why mostly we use in the atrial fibrillation. That's all about the ibutylide and dophytylide. About the amiodarone, the most important thing you have to remember is the IOD. The IOD tells you that there is an iodine presence in the amiodarone. So about 40% of the amiodarone has iodine content, and that is the reason it has the capacity of causing the hypothyroidism or hyperthyroidism. To avoid this side effect, we recently have come up with a new drug which doesn't have the iodine part, and the name of the drug is dronidarone. In this we don't have the iodine, but when compared with the amiodarone, this is less effective. Okay, only one plus point is it doesn't have the side effect of causing the hyper or hypothyroidism. And another important point you have to remember about the amiodarone is its T-half is very long. So when the T-half is very long, the drug, to get the maintenance dose in your blood, it takes a very long time. So it takes a long time for the drug to reach certain duration where its effect can be presented on the body. That is why what you do with this kind of drugs, you give a loading dose. When the loading dose is given, the drug immediately reaches up to its level in the blood and starts acting on the body, and later you give the maintenance dose. So this is the T-half point. And the main adverse effects you have to remember about the amiodarone. So most of the MCQs will be asked, amiodarone can cause which of the following side effect? So there you have to remember the mnemonic, the periphery of my lung, liver, cornea is photosensitive. Okay, so each of these has its own significance. That tells you that it can cause thyroid, and also if you observe the amiodarone very keenly, it has iodine, IOD. That is the reason it can cause the thyroid problems. Periphery for peripheral neuropathy, myocardial depression, lung fibrosis or pulmonary fibrosis, liver toxicity or hepatic toxicity, corneal deposits. Photosensitive is nothing but the rashes will be present on the skin when you use the amiodarone, and it has a side effect causing the blue rash. That is why it has another name, blue man syndrome. And now your brain must tell you about the red man syndrome. Where is red man syndrome? Yeah, it is caused due to vancomycin. You are right. So this is all you have to remember about amiodarone. And the last one we are left with is sotalol. Just a second. Amiodarone has also another important point, that it can block all the channels. Like it can block the sodium channel, it can block the potassium channel, it has the capacity of blocking calcium channel, and also it acts as a beta blocker. But the major action is blocking the potassium channels. And about the sotalol, you might be wondering, this is a beta blocker, so it must be in class 2. Then why is it written in class 3? Yes, the major function of the sotalol is also blocking the potassium, and it can also block the beta. So it has two functions. Okay, major is potassium channel blocking. So we have left with the fifth group of drugs, that is the miscellaneous drugs. We have mainly 4 drugs you have to remember, most important. If you have a patient with atrial fibrillations, digoxin will be used, okay? And if you have a patient with bradycardia or bradyarrhythmias, what you do? For example, if you are an intern who is watching the video right now, you must have known about the atropine. Like, you use the atropine regularly when you have the casualty duties mostly, or AMC duties, because there we have the patients who has the highest risk of death. So in these patients we usually find the bradycardia, the heart rate will be very less. So in these situations, to increase the heart rate immediately, what we do? We take the atropine 1 ml, usually it comes in a small ampule. We take the 1 ml of atropine and we usually dilute it to about 10 cc, and we give the flush of the atropine. So why you use the atropine there? Because it has a property of increasing the heart rate. So this is used as drug of choice in bradycardia and also AV blocks. That is an important drug about the atropine. And about the adenosine, we have few special points, like it has very shortest T-half, so less than 10 seconds. For example, if you take the adenosine and if you give the patient in a peripheral vein, so what happens? It must reach the heart, so it must travel till the heart. During this travel, the T-half of 10 seconds will be completed, and the drug has no effect by the time it reaches the heart. That is why we have the central vein. For example, in few patients who is in very risk of death, what we do? To give the drugs, to deliver the drugs most easily, we insert a central vein into the jugular vein. So the central catheter we use here will be placed into the heart. So it is placed in the jugular vein, and from here when you give the adenosine, you have to push it very quickly. You have to push the adenosine very quickly so that it immediately reaches the heart. So it has less than 10 seconds. It takes less than 10 seconds to reach the heart, and its effect on the heart will be reached or acquired. That is the reason there is another name, rapid IV push. It is the main drug of choice for paroxysmal supraventricular tachycardia. These are the points you have to remember about the adenosine. And about the magnesium, I already said, when you block the potassium channels, what happens? The repolarization takes more time. This increases the action potential duration, thereby increases the QT interval. So there is one syndrome named the long QT syndrome. So in these situations, the drug of choice is magnesium. This is also named by TDP, Torsades de Pointes. Okay, these are all the points, important points you have to remember about the anti-arrhythmic drugs. If you have any query regarding the drugs or any suggestions regarding the video, feel free to comment below, and also you can ask me directly, contact me by the social media networks on Telegram and WhatsApp also. The links are provided in the description. And thank you very much. Don't forget to subscribe. Good luck.